I'm going to spend the next 15 minutes. We're going to do a series of shorter 15-minute talks, and I'm going to talk a little bit about the preoperative evaluation and management of patients with heart failure. We talked about preoperative evaluation and management of patients who might have coronary disease earlier today. There's a lot of data related to patients with coronary disease, very little data for patients specifically with heart failure. And the interesting thing about that is that heart failure is probably the most common post-op cardiac complication. It occurs in 1 to 6% of patients after major non-cardiac surgery, and that risk goes up significantly when there are other existing conditions like diabetes, renal disease, and people going for high-risk surgery. The literature really does not distinguish in the different etiologies of heart failure. So everything that's called heart failure is sort of lumped together, whether it's ischemic heart disease, heart failure with preserved ejection fraction, amyloidosis, chemotherapy-related cardiomyopathies, all lumped into the same category. So some important points to make is that our preoperative evaluation should really attempt to identify signs and symptoms of acute decompensated heart failure. So people that have had a change in clinical status who are coming in for surgery, you definitely want to know about that. Someone who could walk for 25 minutes at baseline who can now only walk for 5 minutes because of shortness of breath, that kind of clinical change, an acute decompensation of their heart failure, you want to know about. Because acute decompensated heart failure approximately doubles the perioperative risk. And if somebody goes into surgery decompensated, their risk is significantly higher. And if we see people with acute decompensated heart failure, their surgery should probably be postponed until we can get them compensated again with medical therapy. Now, heart failure in these various risk models over the decades has always been there. The original Goldman criteria focused primarily on physical exam. When Wittstein did his revised criteria, it focused more on chest X-ray findings. And now in the revised cardiac risk index from 1999 that we talked about earlier today, you get a point just for having a history of heart failure. And to break that down more specifically, you got a point if you had a history of heart failure, if you had any history of pulmonary edema, of PND, bilateral rails, an S3 gallop, or a chest X-ray showing you CHF findings. So any of those in the new criteria in the revised cardiac risk index gives you a point. And in that cohort of patients, if you had a history of heart failure, you were 2 times as likely to have a major adverse cardiac event. But if you had decompensated heart failure, it was almost 3.5 times the risk. So again, the heart failure patient is certainly at higher risk, and particularly if they go into surgery decompensated. This was a large retrospective study looking at almost 160,000 cases of non-cardiac surgery over a 4-year period. And they looked at all the patients were 65 and older, and they looked to see patients who had a history of heart failure, a history of coronary disease, and then about half of those patients had neither heart failure nor coronary disease. And it turns out that the group with prior heart failure diagnoses had the highest risk for operative mortality and 30-day readmission. Having heart failure and coronary disease did not increase your risk over just having heart failure alone. And you can see here that in the red box there that there was an 8% operative mortality in heart failure patients, a 17% 30-day readmission, significantly higher than patients who had a history of coronary disease. So really the group of concern in this retrospective study was primarily the heart failure group, not a big difference between patients who had coronary disease and who had neither heart failure nor coronary disease. So again, a red flag for patients with a history of heart failure as being a particularly high-risk group. When they looked at the different types of surgeries, anything kind of to the right of the vertical line would suggest higher risk. The heart failure patients are in the black, the coronary patients are in the open circle. You can get a sense that no matter what type of surgery we're dealing with, the patients who were at highest risk were the heart failure patients. The coronary patients were not at higher risk for almost every surgery up there. And I know it's a little hard to read, but there's a series of orthopedic surgeries, colon cancer resection, cholecystectomies, AAA repairs, etc. It was the heart failure group that had the highest risk overall. This is a risk score for predicting 30-day mortality in heart failure patients undergoing non-cardiac surgery. And you can see a lot of the things on there are similar to what's found in the revised cardiac risk index. But we see here there's gender, there's age, body mass index, whether it's acute surgery, whether it's high-risk surgery, whether they have kidney disease, cerebrovascular disease, or on insulin therapy. And what drove a lot of the points in this were whether you were older. You can see that if you're greater than 85, you get 7 points. Actually, being underweight gives you points. Obesity is actually a risk, actually decreases risk. And so if you're underweight, you get more points. And if it's acute surgery or high risk procedure, you get more points. And that tends to drive all of the things that we see here. So being old, having high risk surgery, being underweight, and having acute surgery will drive the score up. And if you have a low score, your mortality is less than 2%. If you have a score greater than 20, you had a greater than 50% mortality. So this is something we can easily look at for heart failure patients that are going off to non-cardiac surgery. Now, how should we screen these patients before they go in for surgery? Well, I think we want to get a sense of whether they have a prior history of cardiomyopathy and or heart failure. And if yes, what is the etiology of the heart failure? Is it ischemic heart disease? Is it valvular heart disease? Is it idiopathic? Is it chemotherapy related? It's helpful to know why they have a cardiomyopathy and heart failure. We should know what their baseline functional status is. Can they walk 2 miles? Or do they have a hard time walking from room to room in their house and going up a single flight of stairs? That's a very important question. And I think equally important is, has there been a recent decline in their functional status? What could they do a month ago compared to now? And if you see that they're on the decline going into surgery, that would be a time to take a step back and see what we need to do to get them back on their baseline curve. On physical exam, we should look for signs of congestion, but also low output heart failure. And I'm going to talk about that a little bit more in a second. We talk about low output heart failure, talking about hypoperfusion, signs and symptoms of hypoperfusion. And then what tests should we get? Basic labs, a chest x-ray to look for congestion. Should we get a pro-BNP or a brain natriuretic peptide level on everybody? And who should get an echocardiogram? So when I think about heart failure patients, I really break them down into 2 categories: patients who are congested and patients who have low output hypoperfusion symptoms. So by history, the congestive patient would have exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, maybe abdominal distension, they may have weight gain, they may have lower extremity edema. And these are the patients who on exam might have the elevated jugular venous pressure, they may have gallops, crackles, ascites, a pulsatile liver, pitting edema perhaps. And the tests that you might get would show elevated liver function tests, usually a doubling or tripling at most if they're simply from congestion. They may have an elevated BNP or pro-BNP, and you may see congestion on chest x-ray. So that would be the congestive patient. But you may also see patients who have low output hypoperfusion heart failure who don't have any signs of congestion. They may not have RALs, they may not have edema, but they're actually the highest risk patient, the low output hypoperfusing patient. They may present with fatigue, lethargy, confusion, nausea. Beware of the heart failure patient who complains about nausea and dry heaving. Dry heaving is almost always a sign of low cardiac output in our heart failure population. On exam, you may see hypotension, they may have tachycardia, they may have a very narrow pulse pressure. So that patient who's got a resting heart rate of 110 and whose blood pressure is 100/85, that would be someone who I'd be concerned about who has a cardiomyopathy and heart failure history. Do they have cool extremities, decreased urine output? And when we do tests, these are the patients whose creatinine may have gone up significantly in a short period of time. They may have LFTs that are in the hundreds or sometimes even in the thousands if they're hypoperfusing, and they may be the ones with a rising lactate. So we shouldn't just be looking for signs and symptoms of congestion, but we should also be looking for that low output patient. And some of these low output patients can actually live in a low output state for weeks, months at a time, and be kind of struggling along. These are the ones we'd want to be careful about taking off for surgery. A lot of people have looked at the utility of getting a pro-BNP or a brain natriuretic peptide level going into surgery. Almost every single study that's looked at this has shown that if your BNP level is elevated, you're at higher risk perioperatively. That doesn't necessarily mean that we have a strategy to lower that risk, but it can certainly alert you to the high-risk patient. I would also say that if you have a baseline BNP, seeing a change in that BNP could be a way to alert you to the fact that this patient may be decompensated. So if a person's brain natriuretic peptide level is 200 at baseline, and it's 800 before going off for gallbladder surgery, perhaps it's time to take a step back and reevaluate and to manage this patient before going off for surgery. What about the role of echocardiography? It doesn't seem to add that much to most of the established risk models, although there's new data coming out that may question that, some of which you heard earlier today. I think it's reasonable for a preoperative echo to be done if the patient has a history of heart failure and nobody knows the diagnosis. So if there's a chart that says history of heart failure and we don't know why, I think an echo is important. And here would be a good example of two patients who could have a quote-unquote history of heart failure, one who has an ejection fraction of 20% and has a big dilated left ventricle. The other is somebody with hypertrophic cardiomyopathy who may have an ejection fraction of 70%. Both of them could have a history of heart failure. I think it would be helpful to know going into surgery what type of heart you're dealing with if there's no other information other than history of heart failure. We went over a little bit the guidelines, the ACC/AHA guidelines for getting an echocardiogram or preoperative assessment of left ventricular function. If the patient has dyspnea of unclear etiology, it's reasonable to get an echo. If they have a history of heart failure with worsening dyspnea or a decline in functional capacity, an echocardiogram is reasonable. Notice at the bottom that a routine perioperative evaluation of LV function in patients is not recommended. So should we be getting echoes on everybody? No, but I think in the heart failure population, particularly if there's been a change in their status, an echocardiogram is certainly reasonable. So how should we manage these patients going into surgery? Well, as we mentioned, the patients that are acutely decompensated are at particularly high risk. Surgery should probably be postponed if you examine a patient and talk to them and you're concerned that they've had a decompensation recently. And there is evidence that if they're well compensated, even if their ejection fraction is low, overall mortality is not particularly high. So here are all the different medications that we're used to seeing in patients with heart failure, and you can see that there's not a lot of available data to support the decisions and what we should do with these medications in the perioperative period. From the standpoint of diuretics, if the patient is decompensated, we should diurese them, we should get their volume status as good as we can before going off for elective surgery. What about beta blockers? Well, typically if someone's decompensated, I don't start beta blockers in that setting. If they're on beta blockers going into surgery, I think it's totally reasonable to continue them on beta blockers, but we've learned that it's not a good idea to start beta blockers immediately before surgery. If you have time to electively start someone on beta blockers in the days to weeks leading up to surgery, that's reasonable, but the days are over where we start beta blockade 12, 24 hours before sending somebody off to surgery. That can increase risk. How about ACE inhibitors and ARBs? Very little data, but these agents can cause intraoperative hypotension. I think it's very reasonable, and a lot of people do, even though this is somewhat debated, to hold ACE inhibitors or ARBs in the day prior to surgery, let them get through surgery, and then restart after we're sure that blood pressure is stable. As far as things like aldosterone antagonists and digoxin, there's very little evidence, but I would say that these are medicines I would not start heading off for surgery if they're not already on it, but if they're on these medications, it's reasonable to continue going into surgery. How about the benefits or lack of benefit of using a PA catheter? Well, there was a large study, it's now over 15 years ago, looking at almost 2,000 patients going for non-cardiac surgeries. They were randomized to a PA catheter or no PA catheter. 16% of the patients in each group were heart failure patients. And what they found was that having a PA catheter in, there was no difference in inpatient mortality post-op, and there was no difference in 6 or 12-month survival. The PA catheter group, though, did have the highest risk of pulmonary embolism. So if we look at these patients overall, no difference. People having major vascular surgery, no difference. Heart failure patients, even the sickest heart failure patients, no difference. So again, this is the heart failure group down here. There was no difference in whether or not they were managed with a PA catheter or not. So not something that we typically do on patients going off for surgery who have a history of heart failure. So in summary, and some of the key points that I would make are that patients with heart failure are certainly at risk for perioperative major adverse cardiac events, particularly those with decompensated heart failure going in. We should try to clarify the etiology of heart failure. We should try and clarify their baseline functional status. Whether there has been a recent decline in their functional status is very important. When we examine them, we should be looking not only for signs of congestion, but looking for the patients with the low output, hypoperfusing type of heart failure. They are probably the highest risk patients going in. Pre-op echo, not routinely indicated in stable patients, but for new or worsening signs of heart failure, or if the etiology of the heart failure is unknown, an echo would be totally reasonable. Major elective surgery should be postponed until the decompensated heart failure is treated. Beta blockers should not be started right before surgery, but certainly if one has time in the days to weeks leading up to surgery, it's reasonable. Reasonable to stop an ACE inhibitor or an ARB the day before and to restart after. And then finally, the routine use of PA catheters is not recommended, but in the very tenuous, occasionally hemodynamically tenuous patient, it might be advisable, but not the routine use. And I'll stop there. Thank you very much.